Oh yeah, I wouldn't.
Yeah, thank you.
I wouldn't get rid of him. He's our
mascot.
Yeah, he's our official mascot.
Yeah.
Although he seems to be degrading over time because I haven't touched him, but every time you get your ginger juice on him,
You're blaming this on me.
He seems to degrade quite a bit. Yeah. For those of you just listening, if you want to look at the what we're talking about, I can't really do a close up on him, but Jeff has a little redheaded. He's got a mohawk too. Naked baby that you can fill with water and then it pees when you squeeze it. So it's been our mascot from day one.
Yeah.
Yeah.
So
have you ever, dude? I know, like you don't have kids, but man, if you cut those, because you remember when you were a kid and you took a bath, and then you had whatever squeezy thing was in there, and you could squirt it all over, and then of course you'd squirt a little bit in your mouth or your face or whatever, dude. After a while, those things get like chuck full of mold because how do you clean them when they have that tiny little opening? You know what I mean? And it's just dirty water getting into them because it's your bath.
That's just now occurring to me.
Yeah. I was like, man, that was really good for my immune system when I was.
Yeah, that's what it was. It was we're strengthening.
Disgusting, moldy. And of course it would. It's not like it's distilled water going in there.
Bathtub water.
Just disgusting.
Just squirting your own filth into your mouth.
I know. Yeah. As a kid, it's cool though. Yeah. Dude, I was, so we got to be doing something cool for the 250th birthday of America, right?
Absolutely. The thing is, I don't know how we go more epic than what we already do other than just getting even more fireworks. Like, I don't know.
Yeah, that's a must. That's a must. I remember my kid was asking me, he's like, well, you should spend $250 on fireworks. I'm like,
child's play,
bro. One firework costs $250. Yeah. I'm like, what are you talking about?
Do you understand how much effort and time and money goes into that show we put on?
Yeah. So bigger, better. I mean, yeah, I don't know. Outside of like, I don't know. Are your neighbors still on board?
Different neighbors. They moved, so we'll see. We got new people.
Wait, the across the street people?
Yeah, they're new people now.
They were. I mean, those people, shout out to those people. I don't know who they are.
I don't know who they are either, but they loved us.
Low, like, I don't know, what's a step above white trash, but definitely not like redneck. Okay. I mean, they were,
is there on the tier list, is redneck above white trash?
Because they weren't they weren't like that, but they were like supportive of, you could tell they were, they were redneck adjacent. I like to sit out on a lawn chair that's on its last leg and drink a Bud Light. Like that's
that vibe.
Yeah.
So like awesome people.
Maybe Keystones. Maybe.
Yeah. Got his 30 pack of stones. Yeah. Now we got a young couple with kids across the street from us. So I bet though they seem moderately friendly. I haven't introduced myself to them.
How old are the kids though?
Young.
Like how young? 5.
Okay.
They should be.
Or younger.
Well, you run into problems if they got to get those kids to sleep. But I mean, so
I guess we'll be all right.
Yeah, pissing off the neighbors is a good strat. I mean, I know several fireworks landed on their roof last time, and they were cool with that.
Dude, yeah, the cleanup afterwards, like the street in front of my house looks like bedlam afterwards, even after we clean.
Okay, so so bigger, better showing, but a side quest ought to be potentially burning one of your neighbor's house down. So not on purpose. I mean, this is not an admission of preemptive
So
guilt.
how's it a side quest though if we can't plan it? I mean, it's
just saying like
if it happens, like extra points.
If the collateral damage of the amount of fireworks we set off during Freebird.
Yeah, fair. Okay.
which is,
this seems reasonable.
Yeah. I'm going to get like 5 grand finale style fireworks.
Yes.
With fountains in the front, and then all 5 of them will have to light like 2 at one point, and then 2 or 3 of them after that, all set up like in a pyramid.
That's how we make it more epic.
So we need to get we have
to have recruits.
Yeah, we got to get your nephews in on this, and like so there has to be a group effort because it's gonna, and they have to be bold and daring because you cannot not light it because you're worried.
Yeah, you can't be half stepping up to that.
You have to be okay with getting burned.
You have to be.
It is America's 250th birthday, and if we think about what Washington was doing crossing the Delaware, we can get a little firework burn.
Yeah, and this is kind of like that.
Yeah. All right, folks. Well, that's the show. We'll see you. Jeff's address.
Yeah. Show up.
America. That's so cool. So, oh, dude, hey, we haven't talked for a while on this. I was going to say I have a couple of gym woes that you still go to the gym, right?
No, I stopped. Of course.
Oh yeah, but you just where do you normally go?
EOS.
Oh, EOS. Okay. Yeah. Two new things that came up. One of them's kind of a repeat of another one, but one's like new, and I never even thought about it until recently. So when you go there, do you use a locker?
Now, well, that's a whole other story, but yes, I do.
Oh, okay. Where you ever use the cubbies?
Disgruntled about it. And I use a full size locker.
Okay. Yeah. The cubbies is kind of my go-to because I just keep shit in a bag. Cause I don't know. The lockers are, I had a locker and that's fine, whatever. And at Vasa, they don't make you pay for it. You just, put your stuff in there and leave it. But then
EOS does. Now the EOS cut all the locks, so now you have to bring your own.
Really?
Yep.
Oh, wow.
Yep.
Okay.
I've been paying for a locker for 15 years.
Did they ever tell you not to pay for it?
No, they just cut them off. And they had all of our shit in bags. No warning, no sign saying even anything like, hey, on this day at this time, nothing. Just went there, nothing. And then they gave me a garbage bag full of my stuff. So yeah, now
was it a nice garbage bag at least?
It was mid-tier.
One of those Glade with like fresheners in it?
Yeah, it wasn't one of those. No, it wasn't the bottom shelf garbage bag. So they put some expense to it.
I don't know what the locker room is just gross.
I've noticed.
And for whatever reason, I get to a locker and then everybody, like every dude comes in there at the same time and goes to the locker. This isn't my complaint. And then the ground is always wet. Like if you've ever taken,
I know.
Why is it always?
You gotta have flip flops, dude.
Well, I'm not worried about that. Like I'm not worried about getting infection.
You don't shower there?
No. I don't shower there. But even if I did, screw that, dude. If you get an infection on your feet because something you stepped in, you deserve to die. That's bad genes, dude.
Dude, I will take my chances with flip-flops, man.
More so like if you dare put your foot down and you have socks on, doomsday.
Yeah,
like you now have the worst thing in the world is wet socks, bro. Yeah. Worst thing in the world.
Disgusting.
So I just use the cubbies and I usually shower like here or there's a shower at my office. So thing I was like thinking about was like, okay, you go up to the cubby and you're grabbing your stuff, right? And same thing, somebody comes up behind you, right? And I am actively putting my stuff into my bag and I'm going to move here in a minute. And they're right behind you. And you look back because they're right behind you and they say, oh, I just need to grab my stuff. I'm like, what do you think I'm doing? You think I'm...
Does this happen often?
Yeah, dude, it's often enough that I'm pissed off about it. Like, I'm like, okay, does it look like I'm making a pizza here or building Legos? I am putting my stuff in my bag to leave, which is what you're about to do.
I just need to get
I just need to grab my stuff. Yeah, I'm doing that too. Like, and guess what I would do if you were grabbing your stuff? I would just wait. I don't understand why.
Do they ever make contact with you, like a tap on the shoulder?
No. And I've circumvented it because I hate any type of interaction like that. So now I stand on the other side. And it's wholly inconvenient, but I keep my stuff on top, so then they never even bother me. And then, so now I'm out of that. But then another one, dude, this is like a recurring thing. Like, I love when somebody comes up to talk to you about something.
I'm actually probably that guy that says, I need to get it. I think I'm that guy.
Yeah. Well, now, if you're just standing there, it's a different story. If you're standing there chit-chatting, right, in a place where you shouldn't be chit-chatting, in front of those cubbies, right? It's like dudes who do their lift, they have dumbbells. They have dumbbells, and then they use the dumbbell rack as their post.
Oh,
I'm like, hey, stupid, get out of the way.
Right.
That's why
you don't get the whole dumbbell rack to do your rows. Bro.
That's why at Planet Fitness, I love they have that thing in front. It's like douche realm. That's what it should be called. It's like
realm,
dude. If you are standing that like less than 5 feet in front of the weights,
rack.
The rack, all the dumbbells, that is the douche dimension.
Douche dimension. I like the alliteration.
That you shouldn't be there. But so if you're like trying to flirt with a girl or something like that, get out of the way, dude. You shouldn't be standing in there. But if you're actively you can tell when somebody's packing their stuff up, right? Like you can tell, or just grabbing. They're gonna move. They're gonna move in a minute. Just wait.
They're not hanging out there.
Yeah, you don't need to tap them on their shoulder. Like, what do you think they're doing, stupid? Like they're doing the same thing you're about to do. You don't take precedence over them, like getting their stuff. I don't know why people feel so
devil's
entitled.
advocate on this though.
All right.
So there is at least 2 or 3 people, it's the same dudes every time that I'll come in. I need to get to my locker, and it's like sardine cans. In there, right?
Yeah.
But dude will be clearly just got through showering, still dripping wet, in his towel, sitting on the bench in front of my locker on his phone.
Oh yeah.
And but like just scrolling.
Oh yeah.
Just like when does it become like a good idea that like right here, right now is when I'm going to check my TikTok and I'm just going to look at this feed for the next 15 minutes in my towel on the bench. Well, yeah, there is that. And I do make a point of like, hey, I need to get in here.
Well, yeah, of course.
Yeah.
At that point, like that's a moral obligation that you have.
Okay.
And
glad we're clear.
Even if you don't have a locker in there, like you should, hey, I'm going to get in here, and then just make him move, and then don't even open your locker, just walk away.
Made you move.
Dude, that reminds me when I was at, I love just doing stuff like that. I think back when I was a kid and I would do just mean shit like that for no reason. I remember going to Weber State and up there where it was at Lynn Lecture where they had that round.
Yep.
Okay. And then they had the parking lot there. And I would do this with our buddy Alan, little Alan, not big Alan. And we would be coming out of there. We had parked. I mean, parking there was crazy.
Right.
But they would have people lined up. So they'd have cars lined up waiting. So they'd have like 4 cars lined up in each row, by the way. And there's like 4 rows. So there's 16 cars total waiting for parking spots.
All right.
So they wait for all the students to come out. And they would see as you're walking up to your car, you'd get in and they'd pull in, give you enough room, you'd pull out and then leave, right? Okay. I'd be walking up and I'd go to a car. It wasn't even my car. I'd be like, I'd wave them in. They drive down. I'd be like, oh. I'd walk away. I'd be so mad, dude. It was hilarious just to mess with them.
Yeah.
Dude.
I love you just like do that to amuse yourself at someone else's expense for like no other reason.
No, that was it. They'd be so pissed, dude.
Yeah.
Now they lost their place in line.
Yeah.
They have to circle back around.
And now they're a subject of a story 20 years
dude.
later on a podcast.
Yeah, speaking of mental health issues.
Yeah, it is crazy. Yeah.
Well, yeah, so we watched there was an episode of the Matt Walsh show, and for those of you who don't know who Matt Walsh is, he has a podcast. It's on primarily on the Daily Wire. I mean, you can find it anywhere or whatever. Safe to say he's a conservative commentator.
I can't quite tell if he leans left or right. Like maybe he's on the right.
He definitely leans right.
Yeah.
He's and he made movies like What Is a Woman and Am I Racist and stuff like that. So yeah, I'm not going to go as far to say we're both fans or anything. We heard there was an episode that talked about the mental health industry, and he's done this a couple of times. And I think we had a previous episode that responded to him, and I'm always a sucker for when
he criticizes the hell out of our profession.
Right.
So it's good for us to respond to it.
And don't get me wrong, I love any time we can just bash on our profession because you know how big a fan.
Yeah.
Well, so
we suck.
Well, no. I mean, here's my thing is I think anything that adds to delegitimize what we do, I think we should address it, right? And whether it's good or bad, like if it's something that we as a profession need to work on.
We for sure need to.
Right. And anything that can add to the legitimacy of what we do, we should work on that. We should, get that out there. But anything that devalues what we do, I think we should also highlight that and say, hey, let's stop doing these type of things as well. Like those are things I think that are important. So anytime these things come out, I don't know, burying your head in the sand just doesn't seem like a good idea.
No. Yeah. We want to be able to respond. He offers some pretty extreme criticisms of our field. And and here's the thing is like, as we'll get into, there's, some truth to what he's bringing up, but as we get into it, I think we'll see that there's plenty of stuff we can maybe push back on as far as what he's representing, maybe a more balanced opinion on things.
So, I mean, the basic what would you say the basic premise of the entire podcast was? So he got into a lot, but his take home message was what?
He criticizes medication, specifically antidepressants like SSRIs, essentially saying that as a field, they don't work the way that we have an understanding as to the way they work. And that in some ways they cause quite a bit of damage. And it's I don't know. It's kind of crazy. And this is, if you'll indulge me on how I first sort of learned how antidepressants work, and the way I've since graduate school, the way I've been explaining it to client after client, everybody is essentially the idea is that serotonin is the transmitter that's responsible for, our mood. And the idea is that if you have depression, it's basically an absence of serotonin. And so, you've got the neurons that communicate with each other. And dude,
are you blanket on what's happening?
Yeah. Edit that out.
Yeah.
Yeah.
Well, we don't need. I think this speaks to like the difficulty in explaining what's happening, right? And it turns into, this is part of what I think he gets to in the podcast that he gave us was, he says we take something that either doesn't exist or is really simple to explain, and then we turn it into an extremely nuanced and detailed explanation that it's difficult for everybody to understand.
Right.
And essentially he's saying for me, the take home message was mental health disorders don't exist, which I can't fully get on board with that. It's difficult for me to get on board with that. But this we prepared a couple clips for you guys. Hopefully this, I checked it earlier. Everything seemed to be fine. But a couple of clips on here. This first one is just him talking about disorders and what qualifies as a disorder. So we'll get into that here, and then we'll comment back on what he has to say.
Disorder, skin picking disorder, disinhibited social engagement disorder, binge eating disorder, and avoidant restrictive food intake disorder. They're also considering even more disorders, including internet gaming disorder and caffeine use disorder. Now, the upshot is that virtually every human behavior is now a medical disorder. Even Alan Francis, who oversaw the revision to the DSM, warned that doctors were turning everyday life into a pathology. In the 1980s and 1990s, we were told that we'd eventually have a blood test for disorders like schizophrenia and depression, that we'd be able to prove definitively where these disorders originate in the brain. But we don't have any such blood test in 2026. And while it's true that a very small number of patients who suffer from mental health disorders are later shown after an autopsy to have some form of brain damage, the vast majority of psychiatric patients have no biological marker of their disorder whatsoever. The psychiatric industry simply kept growing, despite the fact that none of their promises actually panned out. And at any rate, as Sass would argue, if a mental illness is indeed the result of a physical disorder of the brain, which it would stand to reason is the case with something like schizophrenia, then it is a neurological disease, not a mental illness. Neurological diseases are obviously real. You can see them in brain scans. Mental illness as a category exists to diagnose diseases that cannot be found in the physical brain. They are not diseases of the physical brain, but of the mind. And this distinction is extremely important, but it's something that most people don't think about at all, including most of the doctors who hand out psychiatric drugs like Pez dispensers. Meanwhile, anyone who criticized the industry, like Sass, was cast aside. New York tried to revoke his teaching license. They wrote him out of every psychiatric textbook. The profession tried to pretend he never existed because they knew he had a point. And that's why in the past 4 or 5 decades, he's been almost entirely vindicated, at least on some of the major points.
So, one thing that I'm thinking about with him, and I guess he has, where I would agree. So prior to that, he was going through a bunch of disorders that were recently added to the DSM-5, right? Yeah. We're on the DSM-5 TR now, right?
Is that right?
Yeah, the text revision. It's got cool colored pages and stuff now too. So that makes it more.
Do you
legit.
own a DSM-5?
No, but one of the a therapist, who shall not be named, a therapist that I've worked with, requested one as if, man, I need this to do something with. I don't know. I mean, it's hilarious because every diagnosis that I use right now is an F code from the ICD-10. You know,
Right.
So I rely more on that. That's for like billing and stuff. But so like one thing that I do think our industry probably does a lot of, and I wish we could get away from, is, you know, pathologizing otherwise very normal behaviors, right? And turning something that is relatively normal into a problem, and or taking like certain criteria that may be met for a particular disorder and saying that they have that, or diagnosing somebody with that without what seems to be the most important criteria in my mind, which is functional impairment. I feel like if you don't have functional impairment,
It's not a disorder.
right. I don't know if it was a colleague of ours or somewhere along the way. I feel like I've heard if it doesn't cause disorder, it's not a disorder, right? And I'm like, oh, that always really stuck with me. And I don't know. Do you feel like that happens? The over pathologizing of otherwise normal behaviors? Do you see that a lot?
Yeah, it seems like it quite a bit.
Yeah. I mean, especially like in our field, working with like sexual behavior problems, right? I mean, and for those of you listening, like we work with sex offense, but there's no diagnosis for a sex offense. I mean, there's paraphilias.
I was just going to ask if that's what you were referring to.
No, I mean, in a paraphilia, I don't know. Do you want to redeem yourself and take a stab at what a paraphilia is?
Yeah, it's sexual interest in like something that's sort of outside the window of acceptable discourse for sexual things.
Like, and one of those being like exhibitionism, right? Like that's one of them. And there's a diagnosis code for exhibitionism. But the idea there being is that you're doing it to a degree that it's almost illegal in the sense that you're doing it, right? It's causing and one of the things that you get attracted to is the idea that other people, the shock that you're seeing in other people, that they're seeing you do whatever sexual thing that you're doing. Yeah. And that is part of the arousal piece. You know what I mean?
Arousal to their reaction.
Right. Yeah. Now I think that can be manufactured and done, like not in a lab, but you could do that in a way that's not illegal and consensual, right? Like where it's almost staged in a way, like exhibition. Like,
of course,
people watching other people do that type of thing is exhibitionistic in its own way, right? And you could do that where all parties are consenting and it's not illegal, but then it doesn't qualify as a disorder at that point.
And right? I don't think that that's the thrill either that drives the paraphilia to begin with.
Well, right. So same thing with like, now the other side of that would be like voyeurism, right? Now I'm watching this. I'm watching, but usually that's the paraphilia, the pathology piece of that is I'm doing that without their knowledge, and I'm doing it in a way that is clandestine or for the most part illegal. I'm doing it, you know, and the thrill or the excitement or the energy that I get from that is where the disorder comes.
That's what drives it.
So, because I remember distinctly, like, I don't know if I think I may have told you this story before, but we were this is in an institution, and these were all adult males, and came onto the TV. There was I think you were part of this too. You weren't there like with the guys, but Victoria's Secret show came on, lingerie show. You know, they walk down the aisle and just underwear basically, and show off, and there's attractive women doing whatever. And dude, everybody flipped out. The correctional officers, other therapists that were part of the and even therapists that we worked with that are part of the sex offense program. And I was like, well, why are you guys freaking out? And they're like, well, they saw naked bodies. Well, I was like, well, they were naked, but I mean, and so what? Okay, so what? Well, they're going to get triggered. Triggered to do what? What are they going to do? Well, they could go masturbate. And I'm like, to images of adult women in their head? Isn't that kind of what we want them to do? Is that a problem for an adult man to have an image in his head of an adult female and masturbate to it? Is that what's wrong with that? You know what I mean? Why turn that into a pathology? But I don't know. Does that?
They probably threw a term like objectification at you.
Sure. I mean, and now you're getting all weird and philosophical about what somebody may or may not be thinking when the simplicity is. So I don't know. I do think that, like he said caffeine use disorder, and I'm like, whoa. It's like, I don't know what qualifies as caffeine use disorder.
You've got it.
Sure. But again, does it cause a disorder though? I mean, I get a headache when I don't take caffeine, but I mean, it's not like I'm jonesing and going through withdrawals or something.
Oh, yeah, over pathologized.
Well, right. Like, I don't even know. I mean, could you, in your practice, could you ethically diagnose somebody with a caffeine use disorder? I mean, what would have to happen in order for you to get there?
I have never considered that. I don't know.
Right.
Yeah.
Well, right.
That I'd have to find what the disorder is.
Well, right.
Yeah.
It was like one time I had to talk this therapist out of diagnosing a nicotine use disorder. And I'm like, okay, tell me about this. Why'd you diagnose him with nicotine use disorder? Well, he smokes a pack a day. I'm like, all right. Okay. But how did you get to the point of a nicotine use disorder? Well, that's bad for him. And I'm like, what now? Does he have lung cancer right now? No, I don't think so. I'm like, okay. Well, it costs money. Was he hurting for that money? I mean, is he behind on his treatment fees? Is he not paying his probation fees? Can he not pay rent? Can he not buy food? I don't think so. All right. I mean, is it interfering with his personal relationships? No, his wife smokes too. I'm like, okay. Is he getting fired from work? I mean, do they not let him work? No, he does smoke breaks. I'm like, okay, I don't see the disorder here then. Part of it falls into, it's none of my business. Do whatever you want, doesn't it?
Well, yeah. Well, and philosophically, what if he did have lung cancer and continued smoking? Would he then meet criteria? Genuine question.
I think to a degree. Okay, so and I get it could cause lung cancer, and I know it raises the percentage of lung cancer by a gajillion, babillion percent or what. That's not what I'm getting at. I'm saying presently, does he have lung cancer? And
right.
I don't know. I don't know is the answer. Okay. I mean,
fair.
Let's say it's terminal and there's no turning back and he's going to die anyway. And he's like, I'm going to die anyway. So I'm like, I don't know if it's a diagnosis. Yeah. Like I would be hard. Now, if it is actively causing medical issues to the degree that it's taking away from, let's say, again, we're doing hypotheticals here. Let's say he's an athlete or something and his smoking is making it more difficult for him to perform and he's lost, been kicked off teams as a result of it. Maybe we're getting to it. Now we're talking about like him having to get away from hobbies that are genuinely interesting to him, and it's impacting his pocketbook, which down the line could impact like his living arrangements and everything else.
Yeah, I guess
we're getting closer, but damn, dude,
I guess
that's really tough. Yeah. So I think for clinicians, I mean, I don't know, when you train new clinicians, like budding clinicians on, hey, when you're looking for a diagnosis, typically, what are you telling them to look for when they're looking for diagnosis to not over pathologize?
That it's actually significantly interfering with their life and like with addictions, and that they persist in still doing whatever the thing is. But the dysfunction piece is the main criteria I'm looking for.
Yeah.
It's interfering with their employment, with their maybe the probation conditions, their happiness, their relationships, some type of impairment, and then they continue to persist in engaging the behavior. Sure.
I mean, continuing to engage in a behavior despite the fact that you tell yourself you shouldn't do it, I don't think is enough. Like, for example, you talked about scrolling earlier. A lot of people say, I don't like scrolling, but then they do it like regardless. Yeah. I mean, if it's not leading to too many problems in your life, I don't know. I mean, even when it came to, we were talking about masturbation earlier, I was like, I don't know, how much is a disorder? Like, that's when they say like pornography addiction. Has that made its way into the new DSM? Have you seen that at all? Well, good. Cause I always think that doesn't make any sense. Like pornography addiction would be the same thing as saying like, I'm addicted to needles when I'm injecting heroin into my body. Like you're not addicted
You're saying
to
pornography is the tool.
Well, yeah, you're not addicted to
the dopamine
pornography.
Surge.
You like, okay. There's one reason to watch pornography, and it's not because of the entertainment value. Okay, nobody's watching this being like, man, good movie, man.
Yeah.
Like nobody's doing that. I think people are addicted to the euphoria or the feeling of an orgasm, not pornography. I mean, certainly pornography fuels it in its own way, but I mean, I don't know. I don't know why.
Thus being the needle.
Well, right. Yeah, that's what I'm saying. Right. I don't know. It's a method by which you obtain the high. I don't think it in and of itself, you can categorize it as that. That just seems weird. And I mean, I'm not down with pornography or anything. Like it's fine. They've like eliminated it from the internet, but or you have to do passwords or VPNs or whatever you have to do. But I just don't like sometimes taking that, like saying, well, how much is too much? And I've seen it in risk assessment tools that we use. And they're like, okay, if they do it more than 4 times a week, I'm like, wait a minute. What if they did it twice a day? I mean, if you did it, I mean, I've had guys tell me, oh yeah, I do it before I go to bed. Okay. And then I do it when I wake up in the morning. Okay. Does it make you late for work? No. Does it interfere with your relationship with your girlfriend? No. Does it take away from family time? No. Does it cost you money? No. What are we talking about here? We're talking about that's too much. That's a disorder at that. See what I'm saying? Mm-hmm. Like it starts to be like, I don't know. And that criteria, that functional impairment is really crucial. Like if you don't have that, I feel like everything else, what are we even talking about?
Right. Yeah.
At that point. So he goes on, and the other piece that he was talking about here, his next clip is going to be about that serotonin thing, yeah. which is pretty big. I mean, it's a pretty big part of the podcast here. So let's see what old Walshy has to say about serotonin.
Serotonin.
It's kind of a silly word.
Can't be that. Instead, the psychiatric industry will tell you that women must have some sort of unusual chemical imbalance in their brain for whatever reason, even though there's no data to support that theory whatsoever. And even though the concept makes no logical sense. If so many women have this chemical imbalance, then how do we even know that it is an imbalance? I mean, what is the right balance? What is the correct chemical balance that all of these other, chemical imbalances are being judged against? Nobody knows. When a doctor says, "Oh, you have a chemical imbalance," oh, so what is that like? What's the right balance? Where are you looking at the right balance, and then you're judging that my balance is not balanced? Where is that coming from? Nobody knows. Nobody can answer that question. And there's never been any evidence to back any of this up. This is from a paper that was published in Nature from researchers at University College London. And I'm going to read it at some length because it remains one of the most extraordinary passages that's ever been published in a medical journal, at least in recent times. It was published in the summer of 2022. And in this article, leading researchers admit that actually there is no basis whatsoever to think that serotonin has anything to do with depression. And that's kind of a big deal since we've been told for more than 30 years, a lot longer than that depression is caused by a lack of serotonin in the brain. That's why they told people to take SSRIs, selective serotonin reuptake inhibitors. But after all that, we learn it's a lie. Quote, "Our comprehensive review of the major strands of research on serotonin shows that there is no convincing evidence that depression is associated with or caused by lower serotonin concentrations or activity. Most studies found no evidence of reduced serotonin activity in people with depression compared to people without, and methods to reduce serotonin availability do not consistently lower mood in volunteers. High-quality, well-powered genetic studies effectively exclude an association between genotypes related to the serotonin system and depression, including a proposed interaction with stress. The chemical imbalance theory of depression is still put forward by professionals, and the serotonin theory in particular has formed the basis of a considerable research effort over the last few decades. The general public widely believes that depression has been convincingly demonstrated to be the result of serotonin or other chemical abnormalities. This belief shapes how people understand their moods. This review suggests that the huge research effort based on the serotonin hypothesis has not produced convincing evidence of a biochemical basis to depression. This is consistent with research on many other biological markers. We suggest it is time to acknowledge that the serotonin theory of depression is not empirically substantiated."
I mean, it's a pretty big deal.
It is weird that we don't measure a baseline for serotonin before giving it and prescribing it.
Right.
You know, it's weird because like I explained this back in graduate school to somebody, and Dr. Darazotis, he's like a I don't know, he's a hippie, and I'm not saying that disparagingly, but he walks by as I'm explaining this. Love Darazotis.
Yeah.
And he's basically pointing out, so I'm explaining all the brain chemical stuff and, you know, the neurons communicating with each other, serotonin, blah, blah, blah. And
he was just walking by?
Yeah, he was just walking by. I was like, because we were doing like a group project, and I was like, given the rundown of my understanding of how
obviously you could smell him because he was a hippie.
Yeah, bare feet. No. But he even said, he even said something like, you know, it's not as actually cut and dry as you're making it out to be, Jeff, and was saying like that's not really how.
Cool professor, he's just walking by and then shits on your point.
Yeah, he roasted me a couple times on some things.
No, I'm kidding. I'm joking. No, I don't know who he is.
Darazotis was awesome. He's a well-loved professor, but I just assumed that he was, you know, like kind of hippie type people are often anti-medication in a lot of ways. I thought it was coming from that type of angle.
Sure. Like all you need is essential oils.
Essential oils, right.
Yeah.
I thought he was coming at it from that angle. And now I'm kind of wondering, like, is he actually identifying that they're like, you know, with like diabetes or measuring blood sugar, A1C.
Or like testosterone. Before you get testosterone replacement therapy, they would measure baseline testosterone, right? For the absence of testosterone.
Yeah, you have to show the absence in order to then say, okay, well, we want the therapeutic effect to be this, and so the dose should be that.
Well, so
and that doesn't exist.
So kind of I looked at so this wasn't the only study. Like before that, he was talking about and referencing a study that talked about how much more diagnoses are related to females versus males. And like, so females are diagnosed way more than males with depression. Right. And so he's like, well, so if that's the case, like, shouldn't the balance kind of be equal? Like, what is it about females? And he kind of goes on to get into like, well, yeah, they're more hysterical because that's what Matt Walsh does. But so basically he makes three big claims. Okay. And first he says, you know, that the whole low serotonin causes depression story isn't supported. To his credit, that's largely right. I'll tell you why. Second, that the medical basis for SSRIs has therefore been debunked, right? That's overstated. One thing when you look at any of these research articles is it's actually kind of impressive how much the researchers hedge if you just like look at the most people for the most part read the abstract. I'm done. Like that's it. Okay. They don't ever look at the methodology. I mean, that's hard to understand anyway, but then like the discussion section, which talks about limitations, you know, so maybe the abstract conclusion, that's it. Limitations are really important because, in this, they hedge quite a bit on what they're saying, you know, and most people do. And then third, that SSRIs, he kind of goes on to say, are broadly dangerous and they may be driving suicide, violence, and long-term sexual dysfunction. And, you know, there's safety issues that we're talking about, but his framing kind of leaves a lot of evidence that doesn't really land. So the article that he's referencing, he put it on there, The Serotonin Theory of Depression, a Systematic Umbrella Review of Evidence. And that's, man, these names, Moncrief, Cooper, Stockman, Amendola, Hengarter, and Horowitz. And this is actually, quick housekeeping note for accuracy, this appeared in July 2022 in Molecular Psychiatry, which is a Nature portfolio journal. That's not the flagship Nature. So I'm not
it's not the Nature magazine.
I'm trying to nitpick, but yeah, if we're just being fair. So they looked at major strands of serotonin depression research, like metabolites, receptors, everything that he was talking about, transporters, tryptophan depletion, serotonin-related genes. And they concluded exactly what Matt said. There's no convincing evidence that depression is caused by low serotonin concentration or low serotonin activity. So where he so that's right, everything he said in that. Where he kind of drives off the road is when he says there's no proof of low serotonin causes depression. Therefore, the basis for SSRIs is gone, right?
That part's
Well, that doesn't follow. And here's the reason. So you and I know a drug can produce a benefit without correcting the original disease mechanism, right?
you mean as far as symptom alleviation?
Well, right. Okay. So aspirin. Aspirin reduces pain without anybody claiming pain is caused by an aspirin deficiency. Like nobody's saying.
I see.
See what I'm saying?
Yeah.
Or acetaminophen will reduce a fever without us pretending that a fever is caused by low Tylenol levels. See,
right.
See what I'm saying?
Yep.
So I get that. Yes, that story is inaccurate, but that doesn't mean that SSRIs, like as a whole, aren't effective. Okay, so I mean, we were just talking about caffeine. Okay, caffeine reverses fatigue in its own way, right? And without caffeine being the missing ingredient in alertness, like that's not how those things
Low
work.
caffeine
Right.
levels.
Right. I don't have a caffeine use disorder because I have low caffeine levels. It's the opposite. Like that disorder is caused by I take 2,000 milligrams a day. Like that's at minimum, right? So the mechanism of benefit and the cause of the condition are two very different questions, which this research paper doesn't get into. So I think where he got it wrong is he's welding those two together and then saying it as like a causal explanation. And, and I don't know. So
Like if A, then B, but
well, right.
Yeah.
Right. I mean, the paper does not prove that SSRIs never help. It doesn't say that. It just proves something narrower, but also still really important for our industry because of the story that you've told clients, that I've told clients, and most of us have told clients, is that the public facing explanation is that SSRIs, was always more of an advertisement than evidence. Like the low serotonin level. So the serotonin pitch was a Zoloft commercial. That's not a chapter in a textbook that we should be referring to, right? So
fair. Yeah.
yeah. So the thing about, and the depression is physical. Why are women prescribed more SSRIs? So because he asked that question, if depression is physical, then why? But I don't know. Outside of women being more hysterical, why do you think that is? Why are women prescribed more SSRIs?
Maybe they seek help more often.
Cue the sexism coming from Jeff. No.
No, legit. I think that women tend to reach out more when they're going through a hard time. That I'm assuming that if we're looking at who's more likely to reach out for help during a case of mental distress, like women might be more amenable to the idea of making that known to their prescriber.
So it could be maybe a little bit more cultural, but also a little like if dudes are kind of taught be tough, shut your mouth, but and maybe women in that regard, you're saying maybe they're just more intelligent, that they needed that emotional intelligence. They know when to reach out for help. Yeah. So now again, he's factually correct here. Okay. I'm sorry, ladies, but just hear me out. Look this up if you want. But women use antidepressants more than men. CDC data from 2015-2018 found antidepressant use among U.S. adults was about 13.2% overall, higher in women than men. So, and he references a study, and this was by Brody and Gu. I hope I'm saying that right. Gu. How do you say that last
Sounds
name?
right.
Okay.
Yeah.
From 2020. Reported roughly 17.7% of women versus 8.4% of men had used antidepressants in the past 30 days. And those numbers are real. Now, he makes a little bit of a rhetorical move, and this is common too when you read these studies. If it's physical, why would women be more effective? To me, that doesn't really survive. And the reason why is lupus. Lupus is overwhelmingly a female disease. Okay. It's the numbers are not even close. Multiple sclerosis skews female. Migraine, thyroid disease, osteoporosis, fibromyalgia, rheumatoid arthritis, all of those have very striking sex differences. Okay. So by kind of what Walsh is saying, I mean, autoimmune diseases, they can't just be a feminist invention, you know what I mean? Like that can't be the reason why those things exist, or osteoporosis can't just be a woke conspiracy. Like, I mean, those are real things. You know what I mean?
Yeah.
So that's what I'm saying is like there are sex differences, and those sex differences have the implications for the diseases that you are more amenable to. Like that's just the reality of it. So, and there's a deeper issue underneath, which is that I think what we were saying is. Yes, well-powered meta-analyses support what he's saying about women, but the reasons are tangled because, I don't know. If you think about hormonal transitions, who do you think has more hormonal transitions throughout their lifetime, men or women?
I'm going to say women.
Obviously, women. In terms of trauma exposure, I mean, maybe minus the military, I don't know, who gets exposed to trauma more often? Women.
Yeah.
Right. Caregiver load. Who's primary caregivers in our society? And then I think the help seeking patterns. I think women are just more, probably more intelligent to seek help when needed. When dudes sometimes dumb, despite their own best needs, sometimes just say, no, I'm just gonna be tough. And, so
yeah, sure.
So when he says, well, nobody can explain this. I don't know. I feel like it's pretty easily explained when you just think about it for a second.
Yeah, that's good.
Yeah. But I don't know. So now when you're thinking about he talks about youth and he goes through school shooters.
Oh, right. Yeah.
That all the school shooters were on SSRIs.
He's kind of doing that implies a bit of like a cause and effect, to just be that, well, school shooters are, I'm assuming, largely unhappy people. You know, if you're the type of person that's intent on just doing like a rage quit on life and taking out a bunch of people with you and then yourself, like you're probably dealing with some emotional problems. And it's like that people that sort of fit that school shooter demographic are going to be overrepresented by mental health concerns anyway. They're going to be on medications. It's not necessarily I think you'll have to go one extra step to show that it's the medication that's pulling the trigger.
Right. So because I don't know if we're getting into a chicken and egg argument necessarily, but I'm saying what you're saying is that somebody who's more prone to violence or self-harm or suicide, I mean, there's probably a correlation between that and mental health issues. And if that mental health issues also has a correlation to prescription drugs, I don't know if that proves that the drugs in and of themselves are causing this.
I don't think it does it. I've heard that bandied about quite a bit by quite a few people that, look at all the school shooters are all on SSRIs. And
what he referenced a study. Luckily, he kind of gives me clues. He said it was published in Pediatrics in 2024. I think I found it. Of course, I know Walsh listens to us. He's one of 12 that listen. So Walsh, correct me if I'm wrong, but this was an article called "Antidepressant Dispensing to U.S. Adolescents and Young Adults, 2016 to 2022." Man, what an obscure name for an article. I can't even tell what that thing's about. Right?
First off, good job tracking out all this research, dude.
Yeah, Chua, Volerman, Zhang, Hua, and Conti. And so the study used IQVIA longitudinal prescription database. So they just took secondary data to look at antidepressant dispensing in the U.S. to people aged 12 through 25. And so Walsh's broad claim in this is that antidepressant dispensing rose substantially in this age group, right? Which is correct, by the way. So again, that's right. What that claims proves, though, is a lot more narrow than what he's trying to say, because it shows prescribing went up. That's it. It does not by itself prove over-prescribing or under-prescribing or pharmaceutical corruption or that drugs themselves are making young people worse. It is a utilization trend. That's all it is. Like
just that prescribing went
it's
up.
Just utilization trends are by in and of themselves descriptive. They're not causal. Like you can't. So the prescription numbers are a thermometer. Like they tell us that the temperature is rising. They don't by themselves like tell us what started the fire. We don't know. And a thermometer, you know, like that, all that's doing is, again, just giving us a trend. I mean, is it something we ought to be paying attention to? Well, I think sure. Yeah. But you can't say, well, yeah, that it's actually causing them to get worse over time. So they're just prescribing more and more, and that's what's making them worse. Like that's an overly broad claim. And then he kind of goes into the one he said 2016, I think this is it. It's called Precursors to Suicidality and Violence on Antidepressants. This is a systematic reviews of trials in adult healthy volunteers. This is in the Journal of Royal Society of Medicine by Mayfield, Dan Borg, and that looks like a zero. Gauche. So the paper, this was a double-blind placebo-controlled trials of SSRIs and SNRIs in healthy adult volunteers. So these were not depressed patients, okay? And the authors found that antidepressants roughly doubled the odds of a composite category of adverse events related to suicidality and violence with an odds ratio of 1.85, and argued that the harms were probably underreported because trial reporting in this domain has been chronically sloppy. So Walsh is right that the paper does exist. That is alarming, right? But remember, these were not depressed clients to begin with.
Right.
So it raises legitimate concerns about, I guess if you're reading that, to me, I think activation, like agitation, suicidal signals, like the underreporting psychiatric adverse event, like all those aren't fringe worries. I think we should pay attention to those. But his summary kind of inflates what the paper isn't trying to say. The study did not show that SSRIs make people commit suicide or kill someone. It didn't say that healthy people now do that, because it didn't say that now these people all killed themselves, okay? It just looked at precursors. So suicide-related events, hostility, activation, psychotic events, and mood disturbance. And all those are serious. I'm not saying they're not. Very clinically meaningful. But they weren't measuring whether or not, like, the research subjects went out and killed somebody. Like, that, like
they were just looking at these, I guess, are these symptoms, I guess? These,
right. Yeah.
You call them precursors.
Yeah. They were looking at that. So, and of course, I mean, you think it would have cleared the IRB if somebody committed suicide because of your study, or went out and killed somebody because you, like, that doesn't even make sense. So they're not the same thing as completed suicide or homicides. And that distinction matters because, I mean, saying that the precursors exist with healthy adults doesn't mean that now they're going to do that. Because, like, if you're an otherwise healthy adult and you take that, and then you notice, oh crap, I'm having thoughts of killing myself, or I'm having thoughts of hurting other people. I mean, what would be your next step? Probably
go do it.
Yeah. You got it. No, well, that's all, folks.
Yeah. No, exactly.
Well, and that, to me, so he brought that into, then he says, well, that kind of validates the mass shooter argument. Like, he listed all the violent offenders. He listed, like, Columbine and the Sandy Hook and all that, and said that they took psychiatric medications. That's just anecdotal, because saying that, like, a lot of mass shooters took psychiatric drugs is saying that, like, people in car crashes saw an ambulance. Like, well, yeah, I mean, the ambulance is there because of the crash. You know what I mean? Like, it didn't cause the crash. So what he's doing is kind of that causation by proximity, like, you know, that, so, which is kind of how you end up. It's like blaming firefighters for fires. Like, you can't do the same thing. So that's what I'm saying. Don't get me wrong, I think that's a safety signal to say, hey, I don't know what's causing this. And more so, hey, what we were just saying earlier, don't over-pathologize and don't over-diagnose and prescribe something to an otherwise healthy individual who doesn't need this, because here's some legitimate problems that can come from this, like precursors to suicide or homicide or violence. Like, that's a good message. That's a good article, in my opinion. That should be something everybody pays attention to.
Exactly. Yeah. And so with some of this said, like, so as therapists, what's our message to clients about this, right? Because, like, there's, you know, people that are taking these things need to know how they work. And this is kind of laying a bit of a goose egg on the serotonin theory behind depression. Mm-hmm. And so, you know, I have plenty of anecdotal data, people in my life, either in my personal life or clients of mine, I'm sure you do as well, that take these medications and report that they feel better and that it's helped them. So like something's going on.
Sure.
And maybe it's not for the reason that we've been told. Something's happening, whether it's, placebo, or maybe it's some other way that the serotonin's impacting the body. So like our message to clients when they're, again, we're not the ones prescribing it, but how do we explain to them if we don't know how it works, but we feel like it might be something that could be beneficial?
I think that's a really good question. And I think that study actually puts us in a better position for showing why psychotherapy is effective, because it pushes you into an affirmative, action-oriented approach versus being passively afflicted by a disease of which you have no control over, right? So this is what I'm thinking about. Like, okay, so if I just have I have depression because of a chemical imbalance by no fault of my own. But now I'm just afflicted with it. And then that just means I'm almost like a victim of this thing, right? And so it's not equivalent to cancer, you know what I mean? Sure, there's certain things you can do to improve the likelihood that you're going to get cancer. But in many cases, people lead perfectly healthy lives, and then they turn an age and then they get it. And then sometimes it's, devastating and legit. Those are just victims of, bad luck, really. That's really all it is. So, but think about the way you talk to like somebody who has cancer. Like think of how doctors talk to people with cancer and how nurses talk to cancer. Like, what are some of the action-oriented verbs or things of encouragement they say to them? What do they say to them?
Well, I'm not sure what you're getting at.
You need to what? Like we need to
what, treat it?
Yeah. There's an F word though. We need to fight this. We need to fight this. Like, and we need to be aggressive.
Oh, I see. When you're saying action oriented, like taking the initiative to not just be a passive recipient to the disease, but to be proactive about it. To now, okay, I'm dealing with cancer. Okay, what's the plan? How do we battle this?
Right.
Yeah, you're saying do that with depression.
Right. And okay, now look.
I see what you're saying.
Now, and also, I think, and I'm not. I wasn't trying to equate this to cancer. I just think there's certain diseases. Cancer is one of them. There's other ones that we all get on board with really quick and we're very supportive of, right? And that we all try to be very, team oriented when it comes to this. And again, we use, when was the last time you heard somebody say, we need to be aggressive against this depression. We need to fight this depression.
It's not really the term used.
They don't use that language, right? And what I'm saying is, okay, if SSRIs do work, and they work more like aspirin and Tylenol, meaning that, well, if I'm fighting a fever, it's not because I'm Tylenol deficient, or acetaminophen deficient, or if I have pain, it's not because I'm aspirin deficient. No, that helps treat that, right? And I think the message to clients is, look, yeah, this sucks, man. I think, and again, well, first, do not over pathologize your client. Okay, make sure there is a legitimate functional impairment before moving forward, because otherwise it can be kind of light what you're doing, right? And if there is, okay, great. We can't prescribe medications, but we can say, hey, go talk to a doctor and, here's some things to think about.
A lot of lifestyle changes too.
Well, right. Now, okay, this is where it gets affirmative, because think about, I think you can't just say, well, I have seen it firsthand. Both you and I have seen this, where people are so depressed that even those lifestyle changes seem impossible.
Overwhelming for them.
Because they can't even get out of bed, right?
Yeah.
Now, I don't disagree. I think lifestyle changes, maybe changes in mood or attitude rather, and how you interact with people have a huge impact on that, right? Exercise, that's huge. But if you're so depressed you can't even get out of bed, okay, if SSRIs offer you an opportunity to make those lifestyle changes, like these are going to relieve those symptoms to the degree that you can make meaningful changes in your life, such that this goes away long term. With the knowledge that eventually, like, my obligation to my client is I want you to discharge and I don't want to see you anymore. And I don't want you to be on SSRIs for the rest of your life. Like that should be
affirmative.
very action oriented
Right.
and trying to move it in that direction versus you need to rely on me. I'm your shaman through this wacky thing we call life. And I'm the only one here that can guide you. No. You should be interacting with me at the very least amount of time possible. Like if we do it in 12 sessions, great, let's try 9. Like that should be your approach
It makes
to clients.
depression winnable,
Right.
too.
And let's
Right.
go. Let's hustle. Let's
Yeah.
go. And sometimes therapists try to get sidetracked on, well, let's talk about your relationship with your father. Like, no, only if it's relevant to what's happening right now.
right.
Like that doesn't mean a lot. And if I need to be action oriented, let's go. And if after that you have a meaningful relationship and they want to come and talk to you once a week or once a month, whatever, dude, that's fine. All that's good for maintenance stuff. But I'm saying we need to be more action oriented and have a better approach on this. It doesn't mean let's stop doing SSRIs. It
Right.
means like talk about them the way they do. And
Yeah, you're not serotonin deficient.
Well, right.
You know? Yeah, this, you know, a little dose of this might help give you the motivational kick in the pants to get that gym membership,
Right.
to go for a walk with your spouse at night with your
And
dogs.
by the way, does anybody, I mean, outside of, do you ever feel compelled to explain how anything works? Like somebody says, hey, I need ibuprofen. Are you like, let me tell you how that works? I don't know how that works.
No, but I get asked it sometimes though.
Yeah.
Like, what the hell's even going on in my head when I take that stuff?
Yeah.
It's been up until this stuff came out. I kind of felt almost smart in a way that I was able to offer up some kind of explanation and talk about neurotransmitters
Right.
and reuptake inhibitors. And it's like, oh, that
Is there any
that's not
problem
accurate.
though, just admitting we don't fully know how it works, to be honest, but it does work. And here's the evidence.
That's going to be that's going to be how I put it.
Well, right. I don't know why that's such a problem. I don't know why that's such a problem. But it was like, I know there's been more evidence on like, it's like EMDR. I'm not throwing shade at EMDR, but EMDR has a lot of evidence for positive outcomes. And they're starting to kind of try to figure out how it works. But for the longest time, be like, well, how does it work? I don't care. I don't know if I care.
Does it work?
Right. Does it work? I mean, outside of an I Am Legend type thing where it cures it and then you turn into a zombie, I don't care. I don't care how it works. I care that it works. You know what I mean? Like that's the most important thing. Like I don't know how anything works.
So
But,
the informed consent would get weird then, but I guess that's for the psychiatrist to figure out.
well, I think the informed consent would be, we don't fully know. Here's the risks, though. Here's the risks.
Right.
And here's the potential side effects. Yeah. I mean, you know, we can fully explain how therapy works. Well, kind of.
Sort of.
I mean, sort of, you know, but then it all turns into, but it all depends on if you do your homework. You know, it just turns into it after. So, yeah, I think that's probably a bit, there's nothing wrong being transparent and honest about those things. And if they choose not to do it, great. Okay, great. Well, let's find another avenue for them. You know, who knows? So to me, that would be how I think therapists should approach. I mean, like, hey, just be honest with your clients. I mean, damn.
Yeah, I have no problem admitting when I don't know something. It's
Yeah.
just like we're sometimes looked at to have the answer, and maybe just having the epistemic humility of saying like, oh,
Yeah.
it helps, maybe.
Yeah,
Try it.
exactly. I mean, like any other med, do you know how antipsychotics work? Okay, a lot of people don't. Like, I mean, I kind of know how lithium works because I took a big seminar on it, but like,
I took a big dose of it.
yeah, took some right before this podcast. But I mean, that's what I'm saying is, yeah, we just don't really know how and psychiatrics, we're still figuring stuff out. It doesn't mean like shut it all down. This paper just says, well, hey, it's not due to low serotonin. Okay, cool.
I know, because that's kind of the direction that Matt seemed to be going, is kind of the shut it all down approach. You know, disavow psychiatry, mental health. It's all bull.
Yeah.
You know, and like that's the vibe I get from the way he presents it.
Right. And he selectively chooses clips of people being very hokey in their practice.
Yeah.
And I understand it. But still, I mean, that's not a true reflection of people who have really good and ethical intentions in our industry. So, I mean, that's really it. But I will I'll post this all on there. I mean, my last thing I put I wrote down, I was thinking I'll put all the sources on here so you guys, I know everybody's going to be looking this up too, but so the serotonin pitch, it's like it's it's been sold like a low battery warning, like your brain is low on serotonin, the pill recharges it, problem solved, right? And that study that we never actually found, they just never found the low battery. The low battery didn't exist.
There
right?
wasn't a battery.
Yeah, that so, and then Walsh takes that whole thing and says, well, the whole device is a complete scam, and the repairman is corrupt, and
it makes you want to kill everything.
Yeah, the battery is what started the house fire down the street. Like, okay, that's. Yeah, you can't turn that into the other thing. Again, sometimes Walsh makes really good points, and he's deliberately provocative to spark conversations like this. But I mean, obviously, do your own research or listen to us. Either way, I think you're in better shape. So
Awesome job tracking down that research.
Cool. Okay. Well, until next time, huh?
Yeah, buddy.
Okay. And that.